Thank you. No. This hearing will come to order, and I want to welcome everyone today. The hearing is entitled Meeting the Need for Interoperability and Information Security, Health IT. Before we start with the hearing, we need to take a moment to deal with some committee business, and I'm pleased to welcome two new members to our committee. The first will be from California. I'm pleased to welcome Ms. Laura Richardson to the committee. She is, as a new member, is also on another committee, will be coming here soon. So we're glad to have Ms. Richardson. She was a member of the legislature in California and brings expertise in that area. And I also want to welcome Mr. Paul Brown. He brings also particular expertise in that he's a physician. And this is a good way to start your first meeting with, you should be one of our witnesses, and we want you to be a full participant. And let me say, Dr. Brown, just in quick passing, you haven't been here long, but you've been here long enough to know that there's a little tenseness in the air sometimes. We hope you can we hope you can find that you can put that aside and come here and feel that you can be comfortable in getting work done. We've had 29 bills out of this committee. All have been bipartisan. All but one have been unanimous. Even Dr. Gingrey had a decent bill that came out of here. There hadn't been I don't think a Democratic or Republican bill that's been introduced that hasn't gotten prompt action, and we want you again to use your expertise to help us to do even a better job here. And you're sitting at the right hand of a good mentor, so I would listen to Dr. Ehlers for his good advice. And since we have some new committee members, we have to update our subcommittee rosters. The new subcommittee roster should be in front of you, and I've asked unanimous consent that the committee do ratify the subcommittee rosters. With that taken care of, I will now begin my opening statement. Over the past 20 years, we have experienced a dramatic change in the way we share information because of the rapid emergence of information technology. Nearly every industry across our economy, from financial services to media to retail, has embraced information technology and integrated it seamlessly into daily operations. Yet the healthcare industry has lagged far behind. The broad use of IT in the healthcare sector could have far-reaching benefits, including cost savings in the billions, improved quality of care, fewer dangerous medical errors, though there are a number of factors that have contributed to the slow adoption of health IT. I believe one of the most significant is the lack of technical standards for interoperability and the protection of patient privacy. I'll also note that this is an area that Newt Gingrich and Hillary Clinton have agreed upon some time back. And now I hope that we can take their agreement and put it into some action. I am sending copies of this legislation to our fellow colleague, Mr. Gingrich, and hopefully that we'll have him one day also that will come and testify here. According to the most estimates, a fully interoperability healthcare IT system could save U.S. healthcare tens of billions of dollars a year and help prevent some of the mistakes that lead to deaths of over 98,000 patients annually. But meeting the challenge of developing and maintaining such a system is not simple. Most Americans get their primary health care at offices with 5 or fewer doctors. These small offices cannot easily afford the initial investment in health IT equipment and software or the time for training on these complicated systems. Doctors and health IT systems developers also face medical privacy laws that vary state by state, some of which do not support the digital exchange of patient information. Much more work needs to be done to update laws and regulations in order to encourage the adoption of this important technology. And let me note that Governor Bredesen of Tennessee and Governor Douglas of Vermont, a Democrat and Republican, have been working on this with the Governors Association. We were in contact with them just the other day. I hope that we're going to be able to have interoperability between Congress and the Governors Association so they can then push down this uniformity of rules and regulations on the local level. But the biggest barrier to the broad implementation of health IT systems is the lack of technical standards to support interoperability while protecting data security. It is wasteful to start investing in technology until we know it is interoperable, as the cost of upgrade to new systems could eat up many immediate cost savings. To achieve the interoperability, we need to have simple technical standards for data formats, data exchange protocols, and other systems communication needs. These will enable different manufacturers and vendors to build and sell medical software and hardware devices that are based on the same underlying communications technologies. Doctors and hospitals are reluctant to invest in health IT systems that are not interoperable with other such systems owned by other healthcare providers. The National Institute of Standards and Technology, NIST, is uniquely positioned to meet this challenge. NIST was instrumental in guiding the creation of standards for the financial services industry and others as they transition to an IT-based business model. NIST also sets and maintains the technical standards for the IT security across the federal government to protect against data theft and unauthorized access. That expertise is essential for helping to create interoperable standards for healthcare IT. In addition to discussing the challenges of implementing healthcare IT systems in the U.S., our witnesses today will also address, I hope, H.R. 2406, which authorizes NIST to increase its efforts to support integration of healthcare information expertise into the United States. This bill is not a complete solution to the problem we are discussing today, but it is my hope that it is a starting point for the broad efforts needed on the part of the federal government, state governments, and healthcare and IT industries to move toward a fully interoperable healthcare IT system. The bill is based on the recommendations of the report by the President's Information Technology Advisory Committee from 2004 and a study by the National Academies from 2005. It instructs NIST to advance health IT integration while working with healthcare representatives and federal agencies to develop technical roadmaps for health IT standards. The bill also requires NIST to create or adopt existing technology-neutral guidelines and standards for federal agencies. It directs the Department of Commerce to establish a senior interagency council on federal health IT infrastructure to coordinate the development and deployment of federal health IT systems. And finally, it mandates a university grant program at NIST for multidisciplinary research in health IT-related fields. And thank you, Mr. Wu, for that recommendation. Secure, interoperable healthcare IT systems are critical for saving time and money, but we cannot lose focus on the ultimate goal of all health policy, protecting patients' lives as well as saving money. I typically do not tell personal stories during hearings, but if the committee will indulge me, I want to share a story that drives home the purpose of this legislation. The committee staffer who has been handling health IT issues is a gentleman named Mike Queer, a very able, capable, bright public servant. Last year, Mike had an open heart surgery and was diagnosed with diabetes. He was concerned what would happen if he ever needed emergency care, so he started keeping a record of every condition that he had, every specialist that he had visited, and every medication he was prescribed on a small card in his wallet. Unfortunately, that card became larger and larger as he had additional situations. That card was the only comprehensive record of care that Mike had available to him. This past August, Mike had a stroke and was taken to the hospital, where emergency room doctors were immediately able to evaluate his pre-existing conditions, contact Mike's team of specialists, and provide him with the best care because they had that card. Now, thankfully, he's now recovering at home, and we welcome him and want him back to finish this legislation. But if those records hadn't been available, who knows what might have happened. I would venture to guess that not many people in this room or in this country take the time to record their medical history on a wallet card, nor should we need to. Technology in this country is far enough advanced that we should be able to expect doctors to access our complete medical records in any emergency situation. So I'm eager to hear from our witnesses' thoughts and recommendations on how to most effectively promote the broad implementation of health information technology systems in the near future to save money, to save time, and to save lives. Mr. Chair, the Chair now recognizes Mr. Hall for an opening statement.
You can call me Mr. Chair if you want to. Mr. Chairman, I thank you for a good opening statement, and I too look forward to learning more about health information technology, interoperability, and information security, as well as about your bill, H.R. 2406, this morning from our very esteemed panel of witnesses. As a long-term supporter, and for Mike, what a wonderful guy he is, and of course we keep him in our prayers. And I admire him for keeping that list there. I started doing that some 80 years ago, and my list got so heavy I couldn't lift it. But Mike is a wonderful guy. He rendered great service to this committee and to this Congress and to his nation, and we have him on our prayer list. And Mr. Chairman, as a long-term supporter of initiatives such as telehealth for rural communities, I understand the value of health information technology. Many sectors of our economy rely on information technology to increase efficiency and minimize errors. The healthcare sector should not be different. We invest $1.7 trillion annually in healthcare, and yet the system is plagued with inefficiency. A recent RAND Corporation study stated that if most hospitals and doctors' offices adopted health information technology, the efficiency savings alone would average over $77 billion a year. Of course, the good things they do far outnumber the inefficiencies, but we, at a time like this, point up the lack of efficiencies and hope to look to you as 1, 2, 3, 4, 5 people that know more about it than we do, or you wouldn't be there. Because we write our legislation based on your information and how you back it up, and then we battle it pro or con. But the study found that hospitals implemented a health information technology system. Around 200,000 adverse drug events could be eliminated if they did. Could eliminate that many annually. Despite these obvious benefits, developing a nationwide HIT network is expensive, and of course, as the chairman said, it's challenging. One of the biggest challenges, I guess, involves sharing information from system to system, also known as interoperability. We have to develop interoperable standards so that the systems being developed today and tomorrow will function together smoothly. In order to address this need, President Bush established the Office of the National Coordinator at the Department of Health and Human Services, and that office has put together a consortium of public and private entities, including NIST, to develop interoperability and conformance standards. This consortium, the American Health Information Community, AHIC, has been working over the last few years on this very important task. And I applaud your efforts at bringing a health information technology bill before this committee, Mr. Chairman, and I'd like to know more about H.R. 2406 and how it will affect the process currently underway at the Department of Health and Human Services. For instance, it appears that the bill would give NIST overall authority for writing standards, procedures, and guidelines for the healthcare industry. If that's the case, I wonder whether NIST is the best vehicle for full-scale adoption of HIT standards. While I certainly agree that NIST has a role to play, it's my understanding that NIST has never before been a body that has set policy. Instead, they've taken an agreed-upon policy and set about standardizing it. Since there's already a vehicle in place that's setting policy at HHS, will this bill derail that process, or will this legislation establish a parallel process between the two agencies? And additionally, I'm not clear on where the money will come from for NIST to undertake HIT initiatives. Will it have to come at the expense of other NIST projects and priorities? The administration asked Congress for $118 million for FY08 for HIT, and it looks like Congress will appropriate somewhere between $60 and $70 million. Will NIST projects be cut in order to compete with what the administration has already undertaken? That's a question I hope that we can get answered today. I think it's clear that we're all seeking to improve health information technology systems as quickly and smoothly as possible, and I look forward to hearing from all the witnesses on this important topic. And, Mr. Chairman, I do really thank you, and I yield back the balance of my time.
Thank you, Mr. Hall. I think you raised some very important issues. Let me make it very clear that we're not interested in this setting any kind of policy. That should not be the case, but rather setting standards, not picking winners or losers, but rather setting standards. They also have a unique situation. They have the test beds, so that once those standards are developed for both hardware and software, that they can get the good housekeeping keeping seal of approval. Know that a small firm or a large hospital can invest with certainty that they're not going to have to or to see this technology be obsolete soon. So you raised some good questions and other things we want to get into. Since this is a hearing starting at the full committee level, we typically go through regular order of bringing things up through the subcommittees, but by virtue of the interest in this particular topic, we decided to start at the full committee level. But I would like to hear from our subcommittee chairman, and I would like to now yield to Mr. Wu for his opening remarks.
Thank you, Mr. Chairman, and thank you for holding this very important hearing. The health sciences continually push the envelope in new technologies, new medicine, and new research. However, healthcare systems lag far behind in information technology capabilities. In an increasingly digital society, paper records are still a primary mode of information transfer in healthcare. Improving healthcare IT will make healthcare more efficient, safer for patients, a better practice environment for healthcare professionals, and may wind up saving some money. We need technical standards to create a functional, interoperable IT network, and we should enhance the relationship between the Department of Health and Human Services and NIST so that they can work together to create the standards of the future. As the government agency which is responsible for creating technical standards, NIST is well equipped to address healthcare IT standards for interoperability and security. I often note the importance of NIST's role in metrology. If you can't measure something, it's not really real in terms of science or economics. Similarly, NIST plays a critical role for interoperability. If there are no standards to guide folks, creating interoperable IT systems will be extremely difficult, if at all possible. While digitizing medical information will increase efficiency, we must also address the issue of security. NIST can also properly develop standards that not only address interoperability, but the need for proper security measures as well. It has done so in the past. I commend Chairman Gordon's work for his work. Chairman Gordon for his work to address the issue of healthcare IT by introducing H.R. 2406. This bill will increase interoperability and security in healthcare IT by directing NIST to continue its work in developing standards. Earlier this year, the House passed my bill to train healthcare IT professionals who are knowledgeable in both information technology and in healthcare so that new IT systems don't sit on desktop as dark boxes. As we move forward with the Chairman's bill and develop secure interoperable IT systems, we need to ensure these systems can be developed and implemented by trained professionals. Again, I commend the Chairman for his fine work and look forward to the testimony of.
Thank you, Mr. Wu, and continuing to try to answer some of Mr. Hall's very legitimate questions. One was about funding, and I just want to state that the COMPETES Act that was passed overwhelmingly by Congress, signed by the President this August, puts NIST on a track to double over the next 7 years, and we hope this will be a part of that, although not take 7 years. And Ms. Richardson, welcome. You were welcome with great flair in absentia earlier, but let me once again point out that Ms. Richardson, as a member of the state legislature in California, comes with a lot of background and expertise. Also, as a freshman, she had her choice of a lot of committees, and she was a top draft choice because she did come with such a good background, and we are pleased that you chose the Science Committee as one of those committees. So welcome, and you are an official member of this committee now. And Dr. Gingrey, now we welcome your opening testimony.
Mr. Chairman, thank you, and certainly I do appreciate your giving Chairman Wu and I additional time to address today's hearing. As you know, health information technology is a topic of great importance to me as a physician member, and so I certainly appreciate you holding this hearing, Mr. Chairman, on developing interoperability standards for health information technology, an area of, as has already been said, critical importance to our healthcare system and an area with so much untapped potential. Health information technology is one of the most promising ways to tackle today's problem of skyrocketing healthcare costs. It's been mentioned by some of my colleagues in regard to the cost savings, but I'm quoting even a bigger number, and this is based on a recent RAND study revealing that interoperable HIT system, if it's implemented correctly and of course widely adopted, would save the American healthcare system more than $162 billion annually. So that's maybe a little bit more than what Ranking Member Hall had said, but who knows? But whether it's $77 billion, $160 billion, you're talking about a lot of money. I mean, there's some potential huge savings in the cost. Of course, in addition, there are numerous other advantages that are also extremely compelling. Properly implemented HIT would enormously increase the efficiency within our healthcare system by increasing access to things like off-site charting and flagging of charts for follow-up on recommended procedures. It has the potential to eliminate duplicate testing that wastes patients' money and time, and yes, often causes patients unnecessary pain and discomfort. As the chairman was talking about in regard to our great staff member Michael, what could have happened had he not had the foresight to have that record on his person. Even more vital is the possibility of eliminating medical errors. And I'm not sure if this estimate by the National Institute of Medicine is correct, but a number of years ago they came out with a study and said that something like 90,000 deaths occur in a hospital setting on an annual basis because of medical errors. It may not be 90,000, but if it's 9,000, it's too many. So I see two important roles for the government in promoting health information technology. First, we must make sure that every provider is able to adopt HIT. And secondly, we must ensure that the technology and standards, this is what the chairman's bill is about, that the technology and standards measure up to the 21st century standards so that health information technology is implemented properly and promptly so that we get the right software. In regard to the first issue, I want to maybe tout my own bill a little bit and to let you know that I'm sponsoring H.R. 1952 in collaboration with Charles Gonzalez of Texas. He's the subcommittee chairman on the Small Business Committee. This bill is called the National Health Information Incentive Act of 2007. The bill that I had introduced as a standalone is a section of Representative Gonzalez, Chairman Gonzalez's bill, but it would encourage HIT adoption by providing optional financial incentives to small healthcare providers and entities to implement such an infrastructure. And I'm so glad that Chairman Gordon has called this hearing to explore the second part of this process, the creation and implementation of HIT interoperability standards. It's vital that these standards are developed in the most efficient way to ensure that HIT is not only implemented quickly but properly and promptly. And I'm looking forward, Mr. Chairman, to hearing from our witnesses, and I thank them all for being here today.
Thank you, Dr. Gingrey. I know you'd rather hear them than me, but I'm so passionate about this. I just want to follow up on something you said about the savings. Right now, we spend more per capita on healthcare than any other nation in the world. Yet, as you know, we're struggling. We have different ways we want to do it, but struggling to try to get all children to be able to have health care. Right now, as you well know, there's a 10% cut looming for doctors in terms of their Medicare reimbursement. And so, but it's the fastest growing part of the federal expense. It's the fastest growing part of our individual, in most cases, our expenses. But we're already spending so much as a nation. It's hard to just keep stacking more money on. And so if we're going to meet these needs, we've got to find a way to find efficiencies within this system. This is a way. We don't know whether it's tens of billions or hundreds of billions, but we know it is many billions of dollars that can be saved. And with these savings, hopefully we can capture that and use those for those other needs within this healthcare system that are so, again, so important to our nation. And so we're going to work together on this bill. We've got other bills we're going to work together on, and I think we're going to meet those needs. Now, at this time, I'd like to introduce our witnesses, who interestingly, we called to hear from you rather than you hear from us, but we're here. We're glad you're here. First is Dr. David Livingstone. He is a clinical professor at Yale School of Medicine, a doctor with the Eye Care Group in Connecticut. He is testifying on behalf of the Alliance of Specialty Medicine, and he was an advisor early on, and again, I thank you for helping. Ms. Noel Williams is the president of the Hospital Corporation of America, HCA, for the ones of you that aren't in our area. Information Technology and Services, she is testifying on behalf of the American Hospital Association, and welcome, neighbor. Ms. Linda Kloss is the Chief Executive Officer of the American Health Information Management Association. We welcome you. And Dr. Michael Raymer is the Vice President and General Manager of Product Strategy and New Business Initiative at GE Healthcare Integrated IT Solutions. GE has certainly been a leader in this area. And Dr. Dingley, I know you have a witness here today, and I would like for you to introduce him.
Mr. Chairman, thank you for giving me that opportunity and the opportunity to have a witness from my district, the 11th of Georgia, the northwest portion of the state. I have 9 counties, and our witness is from Carrollton, Georgia, in Carroll County, almost Alabama, I call it. But that is Mr. Justin Barnes. I've known Justin for a number of years. He's worked very diligently as Vice President of Marketing and Corporate Development and Government Affairs for the Greenway Medical Technologies company in Carrollton, Georgia, and they develop a lot of software programs. Have been at this for a number of years, have recruited actually some general surgeons and some OBGYNs from the community, have many, many years of clinical experience and practice, who are now working with the company to develop in the development. Well, actually, they have developed very impressive software programs for those 2 specialties in particular, general surgery and OBGYN, and it's something that is out there on the market and working very well. Justin's such a smart young man, I thought surely he was a graduate of Georgia Tech, but I had to go over and speak to him to make sure about that, and he said, no, Congressman, I'm a graduate of UMass. I won't try to pronounce Massachusetts because I don't do very good, but a graduate of UMass in legal studies, and I'm very proud to welcome one of our witnesses, Mr. Justin Barnes from Greenway. Thank you.
Do you know, did he have a son that played on the baseball or on the Little League team? Didn't you just win the World Championship? And that's what? How many? Is that 2 out of 3?
That's right, Mr. Chairman.
Yeah.
That's right. Georgia to 2 out of 3. I think one time it was Macon, and this last time Columbus. Not Carrollton, but pretty close.
Okay. So, Dr. Silverstone, if you would please, you can begin with your opening statement. Dr. Silverstone, if you'll hit the button there to make it turn on, we'll all hear you better.
How's this?
Yes.
Wow, that sounds different. Okay, Mr. Chairman and members of the committee, thank you for holding this hearing on health information technology and the need for interoperability standards that will promote and support the integration of private and secure health information enterprises. I appreciate the opportunity to present the perspective of specialty physicians on your legislative proposal, H.R. 2406, which is pending before the committee. I'm David Silverstone. I'm a practicing ophthalmologist at the Eye Care Group in New Haven, Connecticut, where I'm also a clinical professor of ophthalmology and visual science at the Yale School of Medicine and the assistant chief of ophthalmology at Yale New Haven Hospital. I serve as the chair of the American Society of Cataract and Refractive Surgery's Subcommittee on Health Information Technology, as well as the ASCRS liaison to the American Society of Ophthalmic Administrators Executive Board. Today, I am here representing the Alliance of Specialty Medicine, a coalition of 11 medical societies representing nearly 200,000 specialty physicians. First, we would like to thank you for your efforts to advance health information technology legislation and for including specialty physicians in the development process. We believe that your legislation, which authorizes the National Institute of Standards and Technology to enhance efforts to integrate health information enterprises in the United States, will help to promote the widespread adoption of effective HIT. Health information technology has the potential to increase efficiency and quality of care, but this cannot be achieved until we have effective standards for communication and interaction among systems. In addition, the technology has the potential, as you have all indicated, to significantly lower costs in the healthcare industry. In addition, we support the development of an electronic information network that is reliable, interoperable, secure, and protects patient privacy. Specialty physicians have been and continue to be actively engaged in the quality improvement area. Through the development of measure specifications for services and the development of a rational system for collecting, aggregating, and reporting data across numerous public and private insurance programs in the least burdensome way, we have played a pivotal role in shaping the future of our healthcare delivery system. However, in order to continue making progress in this area, we believe that specialty physicians, and indeed all healthcare providers, must employ reliable and secure HIT systems. These systems are a needed and essential component that will help us to continue to participate in these programs and to improve the quality of care we provide to our patients. In addition, these systems will help us to harness medical knowledge to enable healthcare providers to deliver the most effective and up-to-date medical care in an efficient and cost-effective manner. As you know, the adoption of electronic healthcare records and other health-related information technology has been slow, to say the least. According to the eHealth initiative, the healthcare industry invests only 2% of its revenues in IT, whereas other information-intensive industries, such as financial services, invest 11% of revenues in IT in order to improve the quality, diversity, and efficiency of their products and services. We agree that in this age of rapid technological advancement, the slow adoption of health IT by the healthcare industry is undesirable. The absence of an effective HIT system is hampering the introduction of effective treatment plans into mainstream medicine, the effective and efficient evaluation of current practices, and efforts to improve both the quality of medical care and the cost-effectiveness of healthcare delivery. We believe that an effective quality improvement program must incorporate the use of HIT while recognizing the considerable administrative costs that physicians and other health professionals would incur for participating in such a program. Most physicians and other health professionals lack the necessary health IT and administrative infrastructures to participate in the majority of quality improvement programs for physician services. As you know, the typical American small physician practices and physicians not employed by large institutions will continue to face challenges in financing the purchase of integrated HIT systems. In addition, many progressive practices that were early adopters of HIT are now finding themselves with costly systems that are now out of date. The cost of updating these systems will be too great to bear in the light of the pending healthcare service reimbursement reductions and the lack of interoperability standards. Most physicians do not have HIT systems and are watching and waiting. They do not feel confident making such a large investment in health IT because of the cost and the uncertainty of future system compatibility. Therefore, as Congress addresses this legislation or similar legislation in the future, we hope that additional efforts to promote health IT and interoperability include more financial assistance for physicians to obtain health IT. Efforts to ease the burden on physicians seeking to purchase health information technology, especially in the face of annual updates below medical inflation due to the flawed sustainable growth rate formula, are greatly appreciated and also essential. Your bill, which would accelerate the development of interoperability guidelines and standards, is both a necessary and essential step in deploying and utilizing IT effectively and efficiently in our healthcare system. IT systems must use common standards for data transmission, data sharing, medical terminology, communication, security, and other features. Developing these interoperability standards will allow disparate IT systems and software applications to communicate, exchange data, and use that information to both improve the quality of care provided to our nation's patients and to decrease the cost of providing that care. We concur that NIST, with its experience and expertise in electronic commerce, information technology, security, and privacy, coupled with the healthcare component of the Malcolm Baldrige National Quality Program and its expertise in working with the information technology and healthcare industries, is well equipped to address the technical challenges posed by health information enterprise integration.
Thank you, Dr. Silverstone. Your full testimony is a part of the record, and if we're not strict on our 5 minutes, but you're already 3.5 over, so we would want you to explore more of your interest as we go into the questions. And so I will say we have everybody's testimony. We've reviewed that, and Beulah doesn't honk at 5 minutes, and so we want you to get your full thoughts in, but we want to try to move along in an expeditious way. So, Ms. Williams, you're next.
Good morning, Mr. Chairman. I am Noel Williams, Senior Vice President and Chief Information Officer for Hospital Corporation of America, better known as HCA. Of our 192 HCA hospitals, 20 are in 11 congressional districts represented by this committee with over 16,000 employees. On behalf of the American Hospital Association's nearly 5,000 member hospitals, health systems, and other healthcare organizations, and our 37,000 individual members, I appreciate this opportunity to address the committee on the importance of interoperability and security in health information technology. The mission of America's hospitals is caring for patients. Every day, the women and men of our hospitals strive to improve the safety and quality of the care they provide. Research has shown that certain kinds of IT, such as electronic health records, computerized physician order entry, computerized decision support systems, and barcoding for medication administration, can limit errors and improve care, as well as lower cost and improve efficiency. Hospitals have been pioneers in harnessing the power of IT for improvement. Our challenge now is to extend the use of IT to all hospitals, large and small, in both urban and rural areas. Last year, the AHA conducted a survey to assess the state of IT implementation in America's hospitals. Half of hospitals indicated a moderate or high use of IT, up from 37% in 2005. Overall, IT use was higher at larger urban and teaching hospitals, and not surprisingly, those with positive financial margins. These hospitals also reported rates of growth in their use of IT compared to their small and rural counterparts. Despite these impressive gains, there are still obstacles to the goal of universal IT adoption. Hospitals continue to cite cost as a major barrier. Hospitals currently bear almost all the cost, with no increase in payment for the use of these new technologies. And the benefits of IT, such as decreased need for repeat tests, lower readmission rates, and shorter lengths of stay, accrue to those who pay for care by reducing their costs. The lack of interoperability with current IT systems also poses a significant challenge for hospitals. In 2006, 79% of hospitals listed interoperability as either a significant or somewhat of a barrier, compared with 77% in 2000. We commend you, Mr. Chairman, for introducing H.R. 2406 and for your recognition of the critical role health IT plays in improving healthcare delivery in America. Legislation can help create a policy environment in which technology can be best used to support a safer, more efficient healthcare system. We support the bill's assertion that confidentiality and security must be underlying components of any IT standards that may be developed or adopted as a result. Hospitals have and will continue to work diligently to ensure the confidentiality and security of personal health information. We also agree with the assessment of the National Institute of Standards and Technology and its achievements. This organization has, through its standards and process development work in many industries, established itself as a valuable resource to both the private and public sectors. But there are already many, perhaps too many, duplicative efforts launched by the government in attempts to speed healthcare IT adoption. In the past few years alone, the government has created or partially funded several overlapping initiatives. These organizations lack coordination. The AHA believes that what is needed to successfully speed the adoption of health IT in America is a common vision for the future of health IT, a roadmap and timeline for change, a detailed implementation plan developed together with key stakeholders that articulates each stakeholder's roles and responsibilities. We are concerned that H.R. 2406 could give NIST overlapping responsibilities without addressing the key needs of a national interoperable health IT network. NIST core competencies are measurement science, rigorous traceability, and the development and use of standards. While these competencies, combined with NIST resources, could serve as a resource to the public and private sectors, NIST is likely not the organization to provide the transformational leadership required in healthcare. NIST could develop resources for healthcare providers, as it has done for manufacturing, to help hospital leaders improve their performance. Hospital leaders, while striving to achieve higher standards of quality, safety, and efficiency, are limited to local influence within an organization. They therefore must look to national leadership to create an environment that will enable them to make significant investments in IT. There must be a reasonable expectation on the part of hospitals that they are heading toward the same goal and using the same measures of success as every other hospital in the country. Mr. Chairman, it is the mission of every hospital in every community in America to provide the best care possible to people in need. Health IT is a crucial tool in providing safe and effective care to the right patient in the right setting at the right time. We look forward to working with this committee to forge ahead toward a shared goal of improving the reach of health IT and, as a result, our nation's healthcare delivery.
Thank you, Ms. Williams, and welcome, Ms. Kloss.
Gordon, Mr. Hall, and members of the committee, thank you for this opportunity to testify on health information standards and interoperability. I'm Linda Kloss, and I represent the American Health Information Management Association as its Chief Executive Officer. This topic is of great importance to my colleagues in health information management and our over 50,000 members of the association. Today, our professionals are at the front line, sort of in the trenches, if you will, in implementing electronic health records and other health information technologies. This includes health information exchange among providers, new ways for consumers to access their own health information, confidentiality, privacy, security, data integrity, and consumer access are core values we bring to this important work. Before I begin, I want to thank you for your support and passage of H.R. 1467, the 10,000 Trained by 2010 Act. The Bureau of Labor Statistics, our own research, and that of others substantiates the need for more experienced health IT, information management, and informatics workforce to achieve interoperability. And we certainly urge the Senate to follow your leadership in addressing the important health IT workforce issue. Our prepared comments addressed all the questions that the committee put forward, but I want to just concentrate my oral testimony today on subjects relating to integrating healthcare information enterprise. They are, first, the need for uniform and coordinated data standards necessary for interoperability. In other words, some focus for the committee in our discussion on what types of standards we're talking about. And secondly, the need for a stable, long-term strategy for standards harmonization that goes to the point that Williams made, anchored in a vision. Over the past 4 years, there really have been quite remarkable accomplishments in advancing standards for functionality and data interchange for the EHR and health information exchange. However, the discussion on data content standards, what Dr. Silverstone referred to as the medical terminology, the focus on that to date, critical information that makes up the EHR and is actually what's transmitted, has received too little attention. I compare this distinction to building reservoirs and pipelines, but not addressing the quality of the water that's flowing through those pipelines. So I urge that as we're thinking of standards, we expand our thinking to take in the standards relating to clinical terms and contents that are used to describe medical and care services, the critical language of medicine that in fact will be what allows us to achieve true clinical interoperability. These terms and contents making up the language of medicine are embodied in terminologies and classification systems that are used to catalog them so they can be stored, exchanged, retrieved, analyzed. And interoperability really requires the sender and the receiver to understand the exchange and interpret that information correctly. Terminology and classification systems are critical for not only information exchange for patient care purposes, but for public health, quality reporting, and other purposes. But today, we have over 100 terminology and classification systems, and the U.S. has not put in place, as other nations have, a way to ensure a proper foundation for these systems as standards, critical standards for interoperability. Along with our colleagues from the American Medical Informatics Association, AHIMA has looked into this issue. We convened an expert task force and prepared a set of recommendations under a white paper called Healthcare Terminologies and Classification, an action agenda for the United States. And we've provided an extract from that white paper attached to our testimony. It calls for formation of a public-private authority or an entity to be established to ensure that we have robust and up-to-date terminologies and classifications, standards and authoritative ways of keeping track of them. And we also call in that report for research, further research, planning research as to how we're going to do this well in the United States. So as part of the bill before us today, we are pleased to see a focus on research, and we think one of the critical areas for research, in fact, is how we're going to stand up an authority and a process for terminologies and classifications that will really make healthcare information interoperable. As a second area of focus today, we would just speak to, it does ring.
That's not you. We're being, I guess, going into session, so please go forward with your...
Our second area for comment is regarding standards harmonization. We do believe important progress has been made toward adoption and use of EHRs, and we acknowledge the work of the Office of the National Coordinator, the American Health Information Community, the Health Information Technology Standards Panel, and the Certification Commission for Health Information Technology. All of these efforts have really been organized and set in place over the last 4 years, and they have provided a significant boost toward interoperability. We do believe there's a role for NIST, an important role for NIST in bringing both standards development and resources to this. HITSP, the Health Information Standards Panel, has done a lot to harmonize standards and to bring adoption guidelines forward, but this is largely a voluntary effort, and it's suffering from the woes of many hundreds of people working through essentially a voluntary effort that is contract funded, whereas what we do believe is going to be needed is a long-term strategy for standards harmonization. We do believe that NIST, well known for its expertise in information security and other standards, can supply the health information standards harmonization project with ready standards that can be applied and harmonized, and test laboratories contributing to the work of the Certification Commission.
Kloss, so we've just been called for a vote. We have 5 minutes. So if you would like to quickly conclude, then I think we'll have time to hear from the other two witnesses.
I actually can conclude here. I just say that we are ready to work with you in the committee to mobilize all available resources to help with this important effort.
Thanks, Ms. Kloss. And Mr. Raymer.
Well, good morning, Chairman Gordon and committee members. My name is Michael Raymer, and I am Vice President and General Manager responsible for Global Product Strategy for GE's Integrated IT Solutions. I appreciate the opportunity this morning to testify. As a large purchaser of healthcare services, GE very much supports the goal of creating a nationwide health information infrastructure that we believe will save time, money, and most importantly, lives. To that end, we support initiatives to coordinate the work of the various federal and state agencies and the private sector in achieving that goal. It is important, however, that this coordination does not interfere with the valuable work that has been done to date. The National Institute of Science and Technology, or NIST, is charged with developing and promoting measurement, standards, and technology to enhance productivity, facilitate trade, and improve the quality of life. While NIST portfolio is not specific to healthcare, much of the research done at NIST laboratories with respect to advancing the nation's technology infrastructure is directly applicable to the creation of a NHIN, or National Health Information Infrastructure. H.R. 2406 envisions an expanded role for NIST in the development of HIT. GE supports NIST's increased involvement, but not at the expense of processes that have been working well to date. We believe there are 4 areas in which NIST can provide and can be most valuable in advancing this valuable national resource. One is to facilitate coordination among the federal agencies. The 2005 Memo of Understanding between Health and Human Services and the Department of Commerce charges NIST with the responsibility for strategic policy and program coordination among the federal agencies. While such an effort is a lot like herding cats, we believe NIST has the capability and should be given the opportunity to fulfill this mandate. NIST's role would not be to create standards or to certify standards, but to work with other governmental agencies to ensure that existing standards are implemented appropriately. Secondly, we believe that NIST can enhance the already effective HITSP process. HITSP represents a best practice in public-private collaboration. We should be wary of any action that would result in diminishing the effectiveness of this group. That said, we believe it is possible to build upon the current successes of HITSP and CCHIT, and NIST can play a very important role in that process. To ensure this, we suggest that HITSP be specifically recognized in this legislation, and that NIST authorities should enforce federal agency compliance with standards, and implementation should be strengthened. Thirdly, to provide coordination for testing of interoperability standards. The utility of interoperability testing is to demonstrate that products comply with a defined set of standards. Over the past 10 years, the IHE Connectathon has proven to be an effective, transparent testing process. Development of a parallel process is currently being contemplated by CCHIT would waste certification resources on duplicative efforts. To the extent there are testing processes not within the scope of the Connectathon, and there is room for CCHIT or other entities, either alone or in combination in the context of both private and public collaboration to develop their own testing processes. NIST could help oversee these efforts to ensure there is no duplication. Finally, fourth, focus research on areas not covered by HITSP or other public-private sector activities. There is certainly room among all the other activities for NIST extensive research capabilities, especially in areas where the agency has particular expertise. These would include, one, investigating information technology necessary to support pay-for-performance. Secondly, harmonization of security standards and practices. And third, working with the private sector and HHS to provide clarity in HIPAA security regulation and guidance. In summary, NIST has played a role and can continue to play an effective role in coordinating the efforts of public and private sectors toward developing HIT. Our support for extending or expanding NIST participation in these activities is contingent upon the agency leveraging its strengths and not duplicating or reinventing good work that is currently being carried out by other public-private entities. On behalf of GE Healthcare, Mr. Chairman, I want to express my gratitude for the opportunity to share with you our own perspective on creating a nationwide health information infrastructure. I'd be happy to answer any questions that you and the subcommittee may have.
Thank you, Mr. Raymer, right on time. Mr. Barnes.
Thank you very much, Chairman Gordon, Ranking Member Hall, Dr. Gingrey, and distinguished members of the committee and staff. My name is Justin Barnes. I'm the Vice President of Marketing and Government Affairs for Greenway Medical Technologies, a leading provider of integrated electronic health record, practice management, and interoperability software solutions for physicians' practices. It is always a great honor and pleasure to work with members of Congress and their staff, as I believe we all have a common goal to shape the face of the healthcare industry by utilizing the vast contributions that you've heard about today, and also IT that offers healthcare providers, patients, and payers in achieving goals of reduced medical errors, lower costs, better quality, and improved efficiency within our nation's healthcare system. In addition to representing Greenway, I'm a board member of the HIMSS Electronic Health Record Vendors Association, the EHRVA, which is comprised of the nation's leading EHR companies, currently representing roughly 96% of all EHRs implemented in America today. In addition, I reside on the board of the National Governors Association Health Information Protection Task Force and the Certification Commission for Healthcare Information Technology, CCHIT, Privacy Expert Panel. My perspective today will be that of a small business and software and services provider that is actively engaging every facet of the healthcare industry to support developing a national strategy for the widespread adoption of health information technology and for converting this adoption into quality and efficiency improvements. The faster we align incentives, technical standards, and guideline requirements, the faster we improve care, increase quality, contain costs, and save lives. This statement focuses on Greenway's and our industry's dedication to assisting Congress, the U.S. House Committee on Science and Technology, and the National Institute of Standards and Technology in their goals of supporting the integration of the healthcare information enterprise. In this pursuit, Greenway, HIMSS, and the EHRVA support a truly transparent process and equal collaboration of public and private entities. This collaboration has proven recently to reduce barriers with federal regulations as well as barriers with harmonizing standards. Over the past few years, Greenway and the entire healthcare industry has made significant strides with EHR adoption, standards convergence, interoperability, and proven ROI for long-term sustainability of our nation's healthcare transformation process. Specifically, Greenway customer practices now have the opportunity for interoperability among their local community, which encompasses regional care providers, patients, and hospitals. Our customers alone have realized an annual $21,000 to $81,000 of post-implementation return on investment per physician. With paperwork reduced, collections increased, and coding improved, physicians provide a higher quality of care and also operate a more efficient business. While HIT and EHR adoption currently grows at a record pace, we possess the responsibility to ensure that every policy enacted and every rule that is proposed must sustain our current investments in progress. We applaud the focus that the President, Congress, and HHS have applied to this industry transformation, but we must ensure that all decisions are created by entities that have the essential experience, dedication, and factual evidence necessary to put self-sustaining plans and policy in place. An example of a greenway, HIMSS, and the HRVA-endorsed article of legislation is H.R. 2377, the ADOPT Act of 2007, which uses Section 179 of the tax code to provide physician purchasing incentives that can further increase HIT adoption by reducing upfront practice costs over the first year of EHR implementation. This bill is currently introduced in the House. Greenway applauds the efforts to authorize NIST to increase its efforts in support of the integration of the healthcare information enterprise. NIST already plays an important role in public and private sector collaboration, such as integrating the healthcare enterprise, IHE, and the Health Information Technology Standards Panel, HITSP, and that role should be maintained. In addition, NIST should be encouraged to work collaboratively to make these initiatives even more effective, and Congress can assist by formally recognizing HITSP in any legislative language. HITSP is a best practice because of its public and private collaboration, transparency, and use of multi-stakeholder processes like IHE. IHE has a 10-year legacy of standards and testing harmonization with global ramifications, and for that reason, it is imperative for NIST to recognize HITSP and IHE processes. From a financial investment standpoint, it is estimated that the private sector has invested $50 to $100 million collectively in the past few years following IHE, HITSP, and certification initiatives, and that has resulted in healthcare transformation in important areas of HIT adoption and interoperability. More momentum has been created nationally and internationally in these areas than ever before. While this momentum could be better, it is crucial that influential bodies like Congress, the President's administration, and NIST work together to maintain this impetus and not create an alternative, de facto testing standards or certification authority. It is an exciting time to help guide and sustain the momentum in the healthcare information technology industry. We have the opportunity to create the most efficient healthcare system in the world, and while this is a daunting challenge, it is certainly achievable. If we continue to work together in public and private collaboration, build on President's successes with HITSP, and take the prudent and fiscally responsible steps necessary, we will achieve healthcare transformation goals and recognize the estimated $100 to $200 billion of U.S. annual savings with a fully integrated and interoperable healthcare system. Speaking on behalf of the private sector, we are ready as an industry to continue our progress in partnership with Congress and federal agencies in making these goals a reality. Chairman Gordon?
I bet you were getting ready to say something good there.
Thank you.
We have only 2 minutes, so we're going to have to go vote. I hope we'll be back in 15 or 20, and so the committee will be in recess. All right, the committee will reconvene as everyone gets in their seat. Let me tell you maybe more information you need. I have a good friend and mentor who recently died, and I'm going to be a pallbearer, so I'm going to have to leave very soon here. But I'm glad to be able to join you once again. Let's see here. Ms. Williams, you had, I think, indicated some concern about that there's a number of folks working on this issue, and would NIST just be one more, and there's going to be a problem. Hopefully that's not the case. What we're intending, I think the intention is that we need to have somebody who's going to coordinate these activities. And I would remind you back, I guess it was in 1990, that HHS was directed through the Nutrition and Labeling Education Act to develop standards for baby food. 8 years later, they didn't get it done, and so they turned it over to NIST. 6 months later, it was done. That's what we want to try to accomplish. And Ms. Kloss, you have generally been positive about the Health IT Standards Panel process, of which you are a member. But as you point out, it's largely a voluntary organization with a lack of professional staff resources. For such a critical task as advancing healthcare IT interoperability, doesn't it make sense that the primary standards harmonization work to be guided by a federal agency such as NIST rather than a volunteer organization?
Well, we think it's quite important that this process remain a public-private process, and that certainly the resources and services of NIST would be a huge additional resource to HITSP, but there does just need to be some public-private mechanism that, in order to, because it's aiding adoption and learning as we go too.
I think you're right. I think that's really the beauty of NIST, in that it's a non-regulatory agency. So we can bring everyone together without fear of regulation. This is what they did a few years ago with the financial data security. They brought the financial industry together, again, set those, help them through a collaborative process, set those common standards, not picking winners or losers, and then being able to have the test beds there to make sure that they would work. Mr. Raymer, you note that NIST has not yet been allowed to fulfill its role under the Memorandum of Understanding between NIST and HHS, and you further note some of the work NIST is doing through that MOU. So wouldn't you also agree that codifying NIST's role as a central location to ensure development of technical standards would be a worthy endeavor?
Absolutely. I think the testimony covered a variety of things that we would encourage the committee to look at with respect to what their role would be, but we clearly see that there is a need for NIST in the process, and we believe, as it was originally conceived under the Memorandum of Understanding, that would be an appropriate direction for the committee to head, with the caveats that we placed in the testimony.
And back to a real live doctor, Dr. Silverstone. To what extent would improved interoperability with healthcare IT systems at hospitals, labs, and other medical facilities give medical specialty practices the confidence to make the investment in healthcare IT?
Physicians really need to know that the investment that they are making is going to be a worthwhile investment. I mean, our practices are being challenged on a daily basis by reimbursement. And interoperability is that key, that we need to know that the systems that we purchase are going to be able to work with other systems. As a specialty physician, I'm not the primary care provider most of the time, and patients are referred to me, and when they're referred, we have to recreate the wheel each time. We have to recreate histories. We often have to repeat tests because we don't have access to the tests. Very often, patients have been cared for elsewhere, and we might be able to get that data in a paper format. Often we can't even get that. If we could get the data in an electronic format, then we would be able to continue to analyze the data and to put the data that we are creating alongside that and provide better patient care. So that these standards, we feel, are absolutely critical.
That's how we save money and save lives.
Absolutely.
And as I pointed out earlier, there are, most Americans are treated by physicians in practices of 5 physicians or less. And with the reduction in reimbursements, with difficulties that many practices face right now, it's difficult to justify trying to make that investment, particularly if you're not comfortable that it's going to be a long-range investment, and that is that whatever software you're going to buy is going to still be the premium software, or it can be interoperable with the various groups that you deal with. So that's what we want to try to accomplish. But we need to do more than that. And that's what, the purpose of this bill is not to integrate it into the healthcare offices, but rather to establish those, those standards so that software can be developed. Then, quite frankly, we go to Ways and Means, and we go to the Energy and Commerce Committee, where we need to provide incentives, both in terms of making it a government standard, as well as trying to, I would hope we can provide financial incentives for doctors and hospitals through rapid write-off or other types of ways that we would encourage them to get on this system even sooner.
Representative Gordon, I can't agree with you more. I mean, this will absolutely jumpstart the whole process of making health information technology a cornerstone of American medicine, and will enable American ingenuity to really flower. So I congratulate you on this.
Again, I want to thank our witnesses for being here. My time is up. Would like to ask Dr. Baird to chair the committee, and I'm sure that Mr. Hall will give him plenty of help.
Hall? Thank you, Mr. Chairman. Mr. Barnes, you state that the private sector has invested $50 to $100 million on certification initiatives for HIT. If H.R. 2406 were passed into law, could that slow down the progress that's already been made to date? And if so, why? And if no, why not?
In its current form, I think it could be a disruption to the progress that we've made over the past several years. We are committed to the progresses that we've made. I mean, I outlined them in my statement. I think that NIST certainly has a role. We've outlined that here on the panel, and also several members up there. NIST does have a history of public and private collaboration, so as long as NIST followed those guidelines and processes, which I'm sure they would, then they would certainly have a positive influence on the process. But completely owning the process and not laying out, working more collaboratively with HITSB and taking what HITSB has done by name, not just by process or anything else, but literally by name, then I think we could slow down adoption in the progress that we've made. So if we could take specifically HITSB's progress and move that into a forum where NIST has authority and maintain its progress and build upon that as a foundation, then I would support that.
Mr. Rayner, you state that NIST helped to pioneer a, quote, role-based access control technology that limits the type of information that can be viewed by any individual depending upon that individual's function. Can you elaborate a little on that?
Yes, and then specifically its role and application in healthcare as there becomes more widely available and health information system on national health information infrastructure. We think the idea of role-based security is really critical so that those individuals that have the need to know during the care delivery workflow at the appropriate time are given the appropriate access to the information that they need. We believe NIST could play an important role relative to those security standards that could be more widely adopted. And NIST has some history of having successfully done this in other areas outside of healthcare and inside of healthcare.
And you also state in your testimony that you support an increase in NIST involvement, but not at the expense of the processes that are already working well. Would you elaborate a little on that, sir?
Well, I think Mr. Barnes covered that to some extent in his statements just now. HITSP, we believe, has been a valuable process. IHE has the Connectathon that happens each year where even a wider array of vendors each year are coming together to demonstrate the interoperability of their products. So to the extent that NIST would derail current things that are working, we think that it would be better for NIST to apply their resources. Like the one area would be compliance among the federal agencies. It's one of the largest purchasers of healthcare in the world, and certainly in this country. The government would be greatly benefit from the utilization of standards even within its own healthcare delivery system. So I think we've outlined in the testimony some specific areas that are gaps today.
It's an area to be careful in, isn't it?
Yes, absolutely.
And did you crank into your computer the fact that NIST has never before been a body that set policy?
Yes.
You state in your testimony that you, quote, support an increase in NIST involvement, but not at the expense of the processes that are already working well. And you've stated that. Now, do you believe that the passage of H.R. 2406 could potentially hurt progress that's already been made in health information technology?
I think to the extent that it circumvents or slows down the work of HITSP, of IHE, and other successful initiatives, it would be very damaging. I think that, if the committee listens to the testimony today, and I think focus the bill on directing NIST toward the areas in which we are currently gapped from our national health information infrastructure and technology platform, that what you would do would be accelerate the rate of adoption, because you're ensuring that resources are being brought to bear in an area which there's not appropriate focus today.
Well, I think that's a good answer, and I think that when the chairman introduces a bill, it's often that we need to try to support that bill if at all possible, but we need to point out the pitfalls it might show, and I think this is a very good panel to give us those answers, and I think my time's up, so I'll yield back my time. I'll have some questions that I want to submit to each of you in writing, and if the chair agrees to allow us to do that, ask unanimous consent that the panel be asked to answer our questions that we submit to them in conjunction with this hearing.
Without objection.
Thank you, sir. I yield back.
Hall. Sorry I wasn't able, I had another hearing, as we often do here. From what I hear, the situation seems to be that you've got some positive initiatives going forward that seem to be moving at pace. We all recognize that there seems to be consensus that we need to adopt this as quickly as possible. The question is, NIST does not necessarily have to approach this by saying, we are kings here, we're going to set the standards for you. Do you have objection to NIST providing a facilitative role, or maybe that's what you were saying, Mr. Raymer, a facilitative role to work together with the various established processes to see if they can't move things a little more quickly, because it seems that it's going more slowly. So I want to open that up to anybody. And then, and as part of that, how does 2406 relate to that in your judgment?
Well, to respond to your question about facilitation, we think there are some important roles that NIST could play. One is, as I mentioned before, would be to ensure compliance to the standards by the very federal agencies themselves, and the government would benefit from that. Secondly, as you go through any kind of collaborative, both public and private collaborative like HITSP, having NIST be the coordination to ensure that the dialogue continues on the public side within the governmental agencies is kind of being that guiding, facilitating mechanism, we think would be very good. The other area is that there is some good work that goes on with regard to testing and certification today. But as the standards move forward, and let's say in the area of role-based security, there may be a specific thing and a specific role that NIST may play then in covering gaps of where certification or testing activities today are not appropriately validating the interoperability between products. So we do view there to be a role of facilitation, both within government, outside of government, and more importantly, there could be specific roles that NIST might have in providing gaps that would accelerate the adoption of healthcare IT in the country.
Ms. Williams, you seem to have something you want to say. Thank you. You might want to hit your mic there. I'm not sure it's on.
Thank you. Generally concur with Mr. Raymer. We think that NIST is probably could play a strong role in enforcing the standards, perhaps in implementation of those standards. Just not sure that they are the appropriate group to being the public and private sectors in a step.
Awesome.
I would add that with respect specifically to the Certification Commission for Health IT and the work Mr. Raymer just referred to, that organization is now beginning to build a testing resource and is hopeful that there'll be collaboration and that NIST will collaboration and bring its expertise in building testing beds. Secondly, certainly bringing forth standards in the area of security would be very valuable to the work going forward. And thirdly, as I mentioned earlier, we think we need a new mechanism study on how to look at clinical terminologies and classifications and bring that more robustly and squarely into the standards process.
I actually would like to add just a little bit to that, and specifically on the where NIST probably, if they were involved before now, may have could have played a more positive role in the area of CCHIT and certification. They have chosen a testing bed called MITRE, and whereas that could be considered a duplicative process because they could have chosen IHE, which NIST has been very involved in. And from a vendor standpoint, that's expensive for us. We now have to create tools to work with MITRE in their testing bed, and we have tools already that we paid for and use on IHE. So there certainly is a role for NIST in this. Almost wish it was a little bit maybe sooner regarding that CCHIT item. So that's certainly a role to continue on the efforts, yes.
One of the things we're working on elsewhere at a different committee is the whole issue of national health care and approach that. I'm a big believer in ought to give patients upfront information about what their options are, what the empirical data are, and what their costs are. And I think that ought to be standardized across insurance policies so we all get the same kind of information. Is that kind of issue being addressed, or is it right now you're focusing mostly on the technological aspect? But that's related because will your technology allow for that kind of data, both collection and presentation to patients?
Comment that was the reason behind our discussion on classification and vocabularies as a type of standards that we feel have not gotten sufficient attention. It really is the common language of medicine that will allow this information to be understandable across the industry, and more work needs to be done on that to bring together disparate processes for developing, maintaining those systems, and keeping them up to date, creating crosswalks between them, all this internal information management work.
Thank you. My time's expired. I want to yield to Dr. Gingrey.
Dr. Baird, thank you. The entire hearing has been very, very informative, and of course, with the background of the chairman's bill, I think all of us want to understand exactly what role that NIST will have in regard to, if this legislation is approved. And I guess my main question is, the President said a couple of years ago that we want to have a fully integrated, interoperable electronic medical records system, electronic medical records, by 2014, I think was a deadline. I think we ought to get there hopefully before then. I think the need is so great when we sit here and talk about the various studies that suggest the amount of savings anywhere from $75 billion to $160 billion a year, and we just vote on a bill, the S-chip program, which is by anybody's standards a fairly massive expansion We still have 40 million people in this country uninsured. We've got other needs, war fighting, not the least of which. I mean, so we're talking about real money here, and the quicker we can get to the point of achieving those savings and saving lives, the better. So I guess the main question for all of the witnesses, I'll start with Mr. Barnes, my friend from my district, as a courtesy, but, you know, is there something about what we have been doing with ONCHIT and the Office of the National Coordinator, the HITSP, that is just gets into the realm of moving too slow, foot dragging, not getting the job done, and what is it that NIST can do to put on the afterburners, if you will, to make it better, and not to. I think Mr. Barnes was expressing some concern about what would happen to the small vendors, and Mr. Raymer too, in regard to the large vendors. GE, if you've already gone down a certain road based on what ONCHIT and HITSP have recommended, then we don't want to undo all that progress. So that's really my question. What can we do to make it better, other than the fact that maybe NIST is more recognizable acronym than HITSP or ONCHIT?
Thank you very much, Dr. Gingrey. Most certainly, there has been a lot of work in progress over the last couple of years through the ONC and leadership through HHS and by the President. And this progress, I don't think it's going to be, hopefully it will not be undone, but I mean, you heard in my testimony that through standards harmonization, certification, we've really increased adoption. We obviously could have done it, better. There's always a better way to do items and perform tasks. But in my personal opinion, I think that it's gone as smoothly, actually surprisingly smoothly, as any of us had anticipated. There was GE in my company. We initially, when we were embarking upon learning about certification and standards harmonization, we certainly naturally had a lot of questions and concerns. And I think, now speaking from my company directly, we were pleasantly surprised on the progress and how our investments that we've made, my company alone has made over $500,000 in investments in this. And not just on the personal investment side, but also watching what this has done in the industry, watching interoperability come together. So it's exciting. I mean, we're watching our customers. We've got 17,000 across the country that just came from a user conference, and they're excited. They're seeing how interoperability is changing their lives, their patients' lives. So it's out there. It is successful. It could be better. This is where NIST can come in. I mean, they have essential experience. They have long-valued experience in this area of standards and testing. And so I think bringing that knowledge to bear within the current processes would be invaluable. So I mean, I certainly would encourage NIST. The more minds that come together to make this a better process, I think is certainly welcome, just not to modify or derail all of the progress that we've invested in.
I'm short of time, but I welcome any other comments in regard to that. Williams? Yeah.
It's a daunting challenge that we have, and I would say that IT is a tool to help us solve a complicated problem in the healthcare system. It isn't that we don't have any standards. It's part of the problem is that we have too many standards. The National Alliance for Health Information Technology did a survey recently, and the result was that, in fact, we have over 2,000 standards in the healthcare industry, with over 400 organizations that are either developing standards, maintaining standards, or licensing standards. So we need to invest the authority in some coordinating body to sort through all of this that starts with a vision. And the President laid out a very high-level vision for what we need to achieve by 2014. We need to agree on a common vision, sort of on how we're going to get there. And then we need to agree on a set of standards that will help us get there. That would be sort of the rules of the road or the roadmap. So we need need a common vision, we need standards, we need a roadmap, and then we need an implementation process. And perhaps NIST definitely has a role there in perhaps enforcing and helping with the implementation process.
Thank you. My time's expired. Thank you, Mr. Chairman.
Thank you, Mr. Wu.
Thank you, Mr. Chairman. My apologies, I was called away earlier for what I thought would be a quick vote, which took a long time. And now I've been told again I've been called for a quick vote in my other committee, but I'll risk that briefly. And I want to ask this panel a non-standards oriented, a non-NIST oriented question. In field hearings and in roundtables that we held on this topic, in addition to the challenge of interoperability and standards, there are other significant barriers to adoption of healthcare IT, one of them being the misalignment of costs and benefits. For example, if a small medical group were to adopt healthcare IT, they would have to bear the preponderance of costs, whereas a preponderance of benefits would go upstream somewhere, if you will, to Medicare or an insurance company and so on. Do you have thoughts on how to either better align these financial costs and benefits or for some way for the beneficiaries to help finance the cost of healthcare IT?
Well, certainly GE, as being a large purchaser of healthcare services in this country, are concerned about the misalignment that takes place today in the care delivery environment. As I think the movement toward pay for performance, I think, is an important movement, and to have part of the pay for performance tied to in-process clinical measures that are only possible when you have an electronic system in place. So you can choose to do it on paper, but your cost of reporting that in an in-process basis would be more expensive than the cost of the system itself. Also remind that CMS put out 1303-P last fall, which provided a relaxation of Stark and a safe harbor for healthcare entities to offset the costs of donation for physicians. I conducted research last fall.
Mr. Raymer, my apologies. Let me interrupt you. This time they tell me it's really for real, and it's really urgent, but I would like the witnesses, if possible, to proceed to answer the questions, and I look forward to reading the answers. And my deepest apologies to you all for this multiple ring affair that we have going in the Congress.
Okay. Well, I was just going into 1303-P last fall, created the safe harbor and the exception to Stark to allow healthcare entities like hospital systems or integrated delivery networks to offset up to 85% of the cost of the EMR for physicians. I did research last fall with an independent group that identified that regulatory change will stimulate adoption and probably likely double the rate of adoption over the next 3 years by physicians. So, I think it's the combination of a move toward pay for performance that incents based upon in-process measures, and the number one barrier to adoption for physicians in studies that we've done is all about economics. And so if you couple, that reimbursement will be better when you provide better care, and the methodology by which you do that is IT, is one tool to accomplish that.
I would add that we also have to guard against any failure in implementation. That is, these implementations need to go very well, and we need to be seeing providers really benefiting from the technologies. And so the work that you've done on workforce development is key. Additional insights into best practices and workflow improvements. So it's not just getting them in, it's really making them work well in return.
And I would add that that's an ongoing process. In my written testimony, we did outline that hospitals with more advanced IT systems than what physicians currently have could provide help in both hardware, software, implementation, and ongoing support. but we can't do so today because of the physician referral or STARC regulations. Those have been recently relaxed to some extent. We would like to see those made permanent and the relaxation made permanent.
My perspective is a little bit different because it comes from the trenches. It comes from the physician's office. And I've talked to many physicians over the years, especially specialists, and they really want this technology. They can see that at its best, this technology can really help them to provide exceptional care to patients and make that exceptional care the norm. But there's a tremendous problem with the cost, and there's a tremendous fear with the cost. And physicians are small businessmen. Most physicians do not have very close ties to hospitals and don't want those very close ties. They want to remain independent business concerns. And they want to be able to control their lives. And they need to be able to afford it. And they need to be able to know going into the future that they will be able to continue to afford the technology, so that the financial aspects, yes, are a major one, and the financial aspects really need to be addressed. Physicians are also looking at what it takes to maintain these systems in their offices. And as soon as you get interoperability, as soon as you get standards, as soon as you take your hundreds and hundreds of sets of standards and get an organization that can combine them and can take the best of all of the sets of standards and really make them routine, then you're producing a system that requires less maintenance and a system that physicians' offices can really afford. I have the advantage of being in an 11-doctor practice. In that practice, we have a full-time HIT person, a full-time person to manage our networks and our systems, and most practices can't afford that.
I'd like to follow up just with a quick comment here.
It's going to have to be real quick because I've got a couple other members with us.
Well, just real quickly, I think that if I was a physician, I wouldn't think about not investing in technology. They do need to streamline their practices. Most of my customers, which I have a very hands-on relationship with, do not have any HIT staff in their office. They are 4, 5, and 6 doctor practices across America. And they don't, if you have the right system made for your specialty...
Don't interrupt me again for a marketing pitch. I'm just teasing with you, but it sounds a little...
I'm saying if they do their due diligence, then they will receive the benefit.
All right. Dr. Brown.
Thank you, Mr. Chairman. I am a physician. In fact, I'm a primary care provider and work in a... I've done a full-time house call practice the last few years prior to just recently being elected to Congress. When I was in an office and then as a sole practitioner, I looked into doing electronic medical records for my own patients. And what I found after doing a thorough investigation is, frankly, I could not afford it. I don't have Dr. Silverstone's blessing of having a large practice to be able to afford a full-time IT person. And so affordability, I think, particularly for small community practitioners, sometimes where you have 1, 2, or 3 doctors in a practice who wants to be independent, who's not tied to a hospital, is certainly a tremendous problem that we need to face. And I could not overcome the cost. As well as it was difficult for me to try to figure out how to go up the learning curve to be able to integrate information technology into my own practice. The other thing is our local hospital in Athens, Georgia. I've talked to the administrator recently, and they're trying to develop an IT system through Athens Regional Hospital where all the doctors in the community are all tied into one computer system. And I think that's a very laudable goal, but the thing that concerns me is privacy and confidentiality. And I would, in my own practice, all my employees knew that if anything went out of the door of my practice, it was immediate grounds for dismissal, no questions asked. Fortunately, I never had to dismiss anybody, but last year the U.S. Department of Veterans Affairs announced that the theft of laptops, it contained information concerning, I think it's 26.5 million veterans and active duty military members, and we hear about government workers losing laptops all the time with confidential, even top secret information on those computers. And it just really concerns me that people's Social Security numbers, not only in these instances that I just mentioned, but as a medical doctor, I'm really concerned about the privacy of my patients and the confidentiality. And when you set up this information sharing, I see a very real potential for discrimination against parents, for insurability, discrimination in hiring practices, and these types of things. So could y'all please answer to me how we can ensure that confidentiality, how we can prevent the discrimination to my patients in a new IT type of world?
Well, I'll take that on to start with. I think that the conundrum you're in is that the paper record's also not very secure. So the reality is, if you walk in a hospital today and it's got a lot of paper charts, there's ready access to the public to that. The majority of technology solutions that we're talking about is not having the data stored in one location, but more of a federated model where the data resides back in the practice, and the individual practice has control of that. And when you have a patient referred into your practice, that you, with the appropriate credentials, have the ability to go out under the patient's HIPAA concurrence to go out and secure other relevant data, whether it be problem lists, medications, allergies, which are all important things that you'd like to know about a patient being referred into your practice. So we do believe that NIST can play a role, particularly in the security and privacy side, and my testimony talked about the need for role-based security and how critical of importance that will be. So, you know, I think that it's certainly something that's internalized, but it's very personal. So the one thing you can say about healthcare is it affects everyone in this room. And so I think that in both the public and the private area, you know, GE is very concerned about this very issue as you look to the future of genomics, which is a whole nother universe of personal medical information that may or you know, could be accessed. So it is a big concern that we have.
I would add that the Certification Commission for Health IT, in the foundational testing that they're doing for all certified electronic health records, is meeting certain privacy and security common standards, and that those are being ratcheted up over time as all of us learn to use systems with more robust certification and privacy control. So I think that is one of the stepwise processes in the standards deployment now. What we have, however, and what the e-health, the State e-health Alliance and other groups are looking at, is the wide disparity among states and how, in fact, the current law is actually being put into place. We just do have more need for education across the board in practices. It's not all technology standards.
Those buzzers you've been hearing means we have a vote underway, and so we have to just enough time for Mr. Aiken to ask a couple questions, and then we'll
Thank you very much, Mr. Chairman. Actually, one of the questions was asked, I was just curious about the legal problems, but in terms of data security, is that something that we have to change the laws? Because we got pretty hypersensitive about anybody, knowing whether you had 101-degree fever or something. And it wasn't quite that bad, but we really got pretty hyper about this. Do we have to change the laws any in that regard? And is that a big problem?
I'll maybe start with that one. I think that that's probably being scoped right now. I mean, I sit on the National Government Association Privacy Board for that exact reason, and we're looking at all the 50 state privacy laws as well as HIPAA to see what the recommendations that we'll make to all 50 states and to Congress on does HIPAA need to be modified? Does it just need to be enforced, better interpreted, or what do we need to do across state lines? I mean, every state sees consent and authorization differently, and so we're trying to provide guidance, and that is underway currently right now. We meet every month to discuss this and should have some further recommendations at the end of this year. So I don't know if there's a yes or no answer quite yet. There might be by some panel, but
There is a gap, and that is the gap in genetic non-discrimination disclosure, where we have been advocating for law in that area specifically to cover an area of vulnerability.
That's place you do need some additional protection, not easing off on things that already exist.
That's correct.
Are there places where we need to ease off things where we're too strict, or not necessarily?
I think we've always viewed HIPAA as a floor, and that a floor over time, as we gain more experience and get that in place, we should look to, raising the bar as technology enables things like robust audit trails and other mechanisms to really keep raising the bar, and I think we need a commitment to that over time.
I mean, I was thinking when I'm talking about maybe it was too high. I remember there's times when you couldn't tell a dentist that the patient had AIDS or something, and then you have people that their health is at risk and things like that. So I was wondering if we get, if there's a balancing act. I mean, it seems to me there would be a balancing act, not that you're always ratcheting something up.
I think that adding interpretation also might be an answer, maybe a regulatory guideline or regulatory interpretation, maybe not on the legislative side. I think that's what we're trying to uncover, because HIPAA is just misinterpreted, and so unfortunately people interpret it as conservatively as possible so they don't enter any hot water. So I think that's probably what we're still uncovering.
And then the second thing is there, I used to work for IBM, and the magnitude of this question is sort of mind-numbing to me, but is there any single organization now that can do some systems design and at least define some interfaces so that as people design systems that the things can plug together or is this something that is still, but is there any one single organization that is trying to define what the system might look like?
Well, certainly there is, from a standard standpoint, a definition. No one's trying to write a standard that defines one system. In the state of Vermont, GE happens to be the provider of the regional health information infrastructure. And in that we are providing a product, but there's other states that are doing something similar. We are all leveraging the same work product that's coming out of HITSPI. So the standard shouldn't define a de facto product solution. The standard should define what a product should look like, and then there should be the incentive commercially to develop a system that's responsive to those standards.
So it's a two-tier thing. You have some standards, and then you let the privates work those, and that's the way because those of us in government are very sensitive to the fact that we're not as effective as business in terms of being able to put products in good quality. At the same time, there needs to be some kind of guidance, and so is that balance? You think that this bill sets that balance about right from what you see?
I would agree with that. I would say it's exactly what it does do. It provides the framework, the foundation that enables the private sector to be able to come in and create the programs and the systems that we need.
And then my hope is, of course, all of us can see the benefits of it. I'm a prostate cancer survivor, and so you say, well, you're going to go seeds, you're going to get surgery and this and that. And if those statistics are really recorded well, it's going to be a tremendous tool medically to know all kinds of different things. But I'm hoping the day will come when the individual practitioner, that there's stuff that's cheap enough off the shelf that it's not too complicated. But I also walk into a room with computers and they start laughing. So I'm one of the guys that needs 2 IT people. Thank you. We got to go vote.
Thanks, Mr. Aiken. We are down to 5 minutes. I want to thank the panelists and the witnesses and everyone else who attended here. I also want to thank my colleagues. The record will remain open for additional statements for 2 weeks for members and for answers to any follow-up questions. If you have additional things that we didn't cover but you feel are important to submit for the record, please do that. And members, of course, have that prerogative as well. And with that, the hearing stands adjourned. Thank you all very much.
Thank you.
Thank you.
Forgive us for not staying around to chat. We're going to have to run. But we appreciate very much your presence.